So last we're going to talk about multiple organ dysfunction syndrome. And it's hard in your book to really find this. So I'm going to try to kind of summarize it for you. So multiple MODS or multiple, I'm going to say it right. Multiple organ dysfunction syndrome is a failure of two or more organs. And so we really have an issue with impaired perfusion that leads to organ failure. And so what's a little bit hard in teaching it is it really can vary quite a bit based on what you have going on with your patient and what organs start to fail for them. So we might see things like neurological changes. We often see respiratory failure. And when you see ARDS with sepsis, it's a very significant situation, and that patient's risk of dying is much higher. So you might see respiratory failure. You might see some cardiovascular changes. Big one is kidney injury and failure, because when you are taking blood just to the vital organs, the main central organs and the kidneys are not getting perfused. So they're kind of down the line. So I think of it like a stream, and we're kind of getting to the main things first. And so that would be your brain and your heart. And other things like your GI tract, your kidneys, your periphery really are less important down the line. So you might see issues with kidney injury or failure. Another is decreased GI motility or kind of death of parts of the GI tract. So you might hear decreased bowel sounds, you have decreased gas production, decreased stooling, that kind of stuff. So we sometimes have issues with that. Another is liver dysfunction. The liver can sometimes regenerate and do better over time, but we do sometimes see some issues with what we sometimes call shocked liver. And so the liver can have elevated enzymes that indicate that. And then we can also have issues with DIC or disseminated intravascular coagulopathy, in which there's this issue of impaired bleeding and clotting, and then also metabolic acidosis, as we have this great production of lactic acidosis. So you might need to review maybe some of these labs and things that go along with these situations. So let me go back just a bit in order to do so. So respiratory failure, you're probably going to look at your ABG and see how that is, see what the work of breathing is, the respiratory rate, the pulse ox, any intercostal muscle use, all of those situations, chest x-ray, etc. And with kidney injury, just a reminder that that would be your BUN and your creatinine, that you'd see an elevation of those. But those do take a little while to show sometimes. So really paying attention that urine output every hour is really important. We like to see at least 0.5 mils per kilo per hour to indicate adequate urine output. So watch for those issues. Decreased GI motility, I think that would be more based on kind of your physical assessment. Liver dysfunction, you could see issues with regarding your bilirubin, your AST and your ALT going up. And DIC, one of the main ones is your platelet count reduction. And then metabolic acidosis, of course, we see a low pH and a low bicarb. Okay, so for MODS, we really try to prevent it. We really try to note when this patient is at risk for shock and try to catch it in that compensatory stage. If we can do that, if we can get the patient appropriately treated, there are better chances of preventing impairment to the organs. We can see it in as little as an hour that the kidneys can start failing in some situations. So really, that's what the number I've heard, even 45 minutes to an hour. So we really are working very quickly in order to do this. And like we talked about with the sepsis bundle, that's happening within an hour. So we're really working very quickly to do that. We're also supporting tissue oxygenation. So that might be the use of a ventilator, might be the use of ECMO. We might be doing some sedation or some things to help with that ventilation process as well. So we have adequate oxygenation. We do try to feed our patients. Oftentimes we are really poor at doing that. And so they might need some enteral nutrition or parenteral nutrition. And then lots of different supports for failing organs. So this can really vary based on which organ is failing. So if we go back, pardon me, flying back and forth here, but if we have some issues with respiratory failure, that patient will probably be on the ventilator. If we have issues with cardiovascular system, they might be on the balloon pump. If they have kidney injury or failure, they might be on either hemodialysis or continuous dialysis. So continuous dialysis is also called CRRT, or you might hear it called CVVH. So that means continuous renal replacement therapy. CRRT is continuous renal replacement therapy, or CVVH is continuous venous dialysis, I believe. There's different forms of it. Anyway, but maybe if that patient is hemodynamically unstable, they can't tolerate hemodialysis. That takes out too much blood at a time to filter it. So they might be on a continuous 24-hour until stopped dialysis. So there might be supports for that. Sometimes often before we do dialysis, that we consider giving fluids, pressors, diuretics, and then go to dialysis. So fluids, pressors, diuretics, and then go to dialysis. So that can vary based on that. But sometimes those kidneys never recover. Sometimes they do. Sometimes the patient dies. But that is really important to watch that urine output, to consider fluids, to consider vasopressors, diuretics, and dialysis. Some of these others are a little bit harder to treat with regard to needs. Sometimes patients are on heparin or enoxaparin. For DIC as well. Sometimes for metabolic acidosis, they might be given a little bit of bicarb perhaps, but some of these are a little harder. But overall, we really try to support the perfusion of those organs to help them. So that is a lot. Shock is a lot. We're going to talk about shock a little bit in class, mostly with regard to a case study that includes multi-organ issues. So I hope that you'll find that helpful to you to help pull this all together. And we'll be working in some assigned groups to do that. Here's a QR code for my office hours if you ever need that. And if those times don't work for you, then you're more than welcome to email me. We can find a time that works. Also, if you ever need an enrichment session, let me know. I would consider our time after class to kind of be enrichments. So if that time works for you at 10 o'clock in room 404, I'm glad to see you there as well. Thank you so much. There are also some practice questions here. These are through Khan Academy, and these are some shock practice questions. So go ahead and do those if you like to, and you can get some good feedback on how you're doing on all this new content.